And thank you so much for attending this afternoon session titled Leveraging Data to Strengthen Hepatitis B and Tuberculosis Elimination Strategies Workshop. My name is Fayette Turax, and I will be the moderator for this afternoon. If you have any questions, please enter them in the comment box to the right, and we will get to them after the presentation is done. So I have the honor of introducing both doctors today. The first is Dr. Amit Chitnis. He is an internal medicine trained physician and infectious disease epidemiologist. He received his MD from the University of California, San Diego, and his MPH from Columbia University. After completing his internal medicine residency at the Medical College of Wisconsin, he completed the CDC's Epidemic Intelligence Service Fellowship. For the past 10 years, Dr. Amit has worked in applied public health and clinical medicine. Currently, he leads the Alameda County Public Health Department's TB control section and sees TB patients at Highland Hospital. His public health and clinical interests are in tuberculosis, chronic hepatitis B, influenza, and healthcare-associated infection. Our second presenter is Dr. Robert Wong. He is a clinical associate professor of medicine in the Division of Gastroenterology and Hepatology at Stanford University School of Medicine, and a staff physician in the Gastroenterology and Hepatology sections at Veterans Affairs Palo Alto Healthcare System. He completed his GI and Hepatology Fellowship at Stanford University School of Medicine, where he also finished his master's in epidemiology and clinical research. He is a fellow of the American College of Gastroenterology and is actively involved with the American College of Gastroenterology and American Association of Study of Liver Disease Committees. His clinical interests include management of patients with complex liver diseases, including viral hepatitis, hepatocellular carcinoma, and non-alcoholic fatty liver disease. His research focused on epidemiology and outcomes in patients with chronic liver disease and healthcare disparities among underserved minority populations. Thank you very much, and we're so excited to have you both here. Dr. Chitnis?
Great. If we could just go to the first slide, please. Let me just see okay, perfect. So, as mentioned, we will be, our talk's entitled Leveraging Data to Strengthen Hep B and TB Elimination Strategies. And both Robert and I will be speaking, I'll be starting off the discussion and really walking through how we got started and interested in TB hepatitis B. So next slide. So objectives for the talk, we'll read the epidemiology of tuberculosis, which we'll refer to as TB, and chronic hepatitis B virus infection, which we'll probably refer to as chronic hep B, CHB or HBV interchangeably in the United States. We'll discuss our attempts to estimate TB and chronic hep B and latent TB and chronic hep B co-infection prevalence in the published literature, in the National Health and Nutrition Examination Survey, and a large national laboratory database. We'll describe testing practices for LTBI, or latent TB infection, and chronic hep B in a large national laboratory database, and LTBI screening in clinical trials evaluating chronic hep B treatments. And finally, we'll provide an estimate of the prevalence and risk of drug-induced liver injury among persons with TB and chronic hep B co-infection compared to patients with TB disease only. So next slide. So, I'd be remiss in not acknowledging a little bit of how we got started. Robert and I working on TB and hepatitis B. So as point of context, as Dr. Nguyen mentioned, I see patients at Highland, and Robert also used to be at Highland. The TB clinic would be Wednesday afternoons, and then the GI clinic was Wednesday mornings. So we occasionally crossed paths, and we had some common patients that we had. So really, I think, the way all of our interest had started on this was we just had some mutual patients that we were discussing that resulted in our desire to kind of want to further understand the epidemiology of TB and chronic hep B. So, I wanted to highlight, two of the patients. One was a 60-year-old Burmese male who was status post-liver transplant about 6 years ago now, and had hepatocellular carcinoma and hep B-associated cirrhosis. And he had what was described in the medical record as possible LTBI treatment with INH for 6 months. He developed mild cough and was diagnosed with smear-positive pulmonary TB. So I think, and I'll go through, I think, some of the main points from these patients. But the second one was a 50-year-old Afghan male who arrived in 2015, was diagnosed with smear-negative, culture-positive pulmonary TB in another state, and then started TB treatment in California and Highland Hospital. And it was unclear if he was ever screened for chronic Hep B in the past. And at Highland Clinic, we diagnosed him with hepatitis B virus infection. He was hepatitis B surface antigen positive, Hep E antigen negative, and had about 2,000 copies of hepatitis B virus DNA. So I think, the main point that I think that Robert and I had, sort of discussed about some of these patients and some other ones was there was obviously the clinical challenge of how are we going to treat these patients for TB and hepatitis B and hopefully avoid drug-induced liver injury. But I think it also started us thinking about, are we doing a good job of screening for the opposite disease in our respective clinics? So, are we doing a good job screening for Hep B among TB patients or those with LTBI, and then vice versa in Robert's Hep B clinic, where he's also seeing Hep B patients and also liver disease patients? Are they screening for LTBI? So this kind of started us really on several projects and analyses that we'll describe moving forward. So next slide. So I think, one of the first things that we started to want to understand after, coming across these few mutual patients was, what was written in the literature about epidemiology of TB and chronic Hep B, and what can we surmise by reviewing the literature, and how can we determine what optimal prevention strategies may be needed. So, we embarked on this work with, Robert and I and Ramsey Chung and Robert Gish. And I think, we'll highlight in the next slide some of the main findings, but I'll tell you there's, probably, three main findings that we would just share is that, non-US, starting from the third sentence on in the abstract, that, non-US born persons have a higher incidence of TB than US born persons, 15-fold. They have a 6-fold higher LTBI prevalence and a 8-fold higher chronic Hep B prevalence. And all these infections, both active TB, LTBI, and chronic Hep B, disproportionately impact non-US born Asians. There's also substantial mortality, about 10% with both active TB and chronic Hep B. And they both result in, 7 and 14 years per life loss, respectively. So I think, both obviously are preventable infections. And, we did also note that there are substantial gaps in the cascade of care. About 40% of LTBI and 20% of chronic Hep B patients are diagnosed, and only about a 20% receive treatment. So, we felt there was a lot of room after reviewing this literature where there's a lot of room for potential changes at the healthcare, provider system and policy level interventions, which we'll walk through in a couple slides. So next slide. So this is a dense table summarizing the epidemiology of TB, latent TB infection, and chronic Hep B, and I'll walk through some of the salient points. So next slide, Chef. Next. Hit next. Yeah, perfect. So in terms of the epidemiology of TB, which is that second column, we did note that TB rates significantly decreased among U.S. born, when in one paper from 2013 to 17, but there really were no changes among non-U.S. born persons. So next. Okay, and then in terms of demographics, we did note that for TB and LTBI, the TB rates were highest among non-US born Asians and persons aged 65 and older. And for LTBI, really, non-US born persons have higher prevalence than US born. And it was, non-Hispanics, Asians, Hispanics, and non-Hispanics, Blacks that had the highest LTBI prevalence. Next. And, as I mentioned earlier, TB is associated with about 7 years per life lost. And there were substantial gaps in the cascade of care from what we noted, about 72% receive a diagnostic test, 44% were diagnosed with LTBI, and about 31% accept LTBI treatment, and 19% complete treatment. So again, I think opportunities to improve care both at the individual population level. And then next. So now we're going to highlight a little bit of some of the review of the chronic Hep B epidemiology. So again, about only 32% of patients with chronic Hep B and NHANES were aware of their infection, knowledge, or HBV prevention practices. We're sort of suboptimal in this survey of patients, and only about 20% of insured chronic Hep B patients have been diagnosed with Hep B. So again, opportunities to ensure that individuals increase testing and are aware of their diagnosis. Next. I think, again, we'd like to highlight again, non-US born have higher Hep B prevalence. The prevalence was highest for non-US born from Africa, Asia, Oceania, and Caribbean. And Asians and non-Hispanics have the highest prevalence. Next. And, finally, again, reiterating that, chronic Hep B is associated with 14 years per life lost, and there are substantial gaps, again, in the chronic Hep B cascade of care. An estimated 20% of patients are diagnosed, less than 50% received appropriate laboratory and radiographic monitoring, and 20% of diagnosed patients are started on Hep B antiviral therapy. So again, I think in summary, you have two, sort of diseases that are preventable, associated with substantial morbidity and mortality, with sort of suboptimal cascade of care. So next slide. So I think the purpose of the review is to review the data and provide some strategies for where we think there might be improvements for prevention at the various different levels. And in the column on the first column shows that the various different stakeholders, the healthcare provider, the healthcare system, public health, and policymakers. So I'll next I'll sort of walk through this, but I won't read everything. So next we'll animate for healthcare providers. I think what we obviously would want to stress is prioritize screening and treatment of LTBI and Hep B among non-US born persons, given the overlapping epidemiologic and demographic risk factors. I think there'd be a big emphasis to vaccinate persons who are at risk for Hep B vaccination. There are newer vaccines that, as folks know, where the vaccine series can be completed much faster in about a month as opposed to 6 months. And really use shorter course LTBI treatment regimens were some of the main things that we highlighted in this section, and also ensure as much as possible that patients with Hep B receive appropriate laboratory and radiographic monitoring and treatment in accordance with guidelines. So I think in summary is just screen and treat those individuals and try to use vaccines that can be completed the fastest and LTBI treatment regimens that can be completed fastest, and ensure you monitor these patients. So next animation to the healthcare system. I think here we did feel that there was a lot of potential for collaboration at the healthcare system level. I think, requiring electronic medical records to have reminders and best practices for LTBI and Hep B screening and treatment, Hep B vaccination and lab and radiographic monitoring would, we think, make improvements in the cascade of care. We do think there's opportunities to implement quality improvement projects to increase LTBI and chronic Hep B screening and treatment, Hep B vaccination and monitoring of chronic Hep B infected persons. And similar to some of the other talks we heard earlier today, but I think we'd be remiss in not acknowledging that, we have to develop and invest in multidisciplinary clinical teams for the management of LTBI and chronic Hep B that include patient navigators to help some of our patients, get through the healthcare system. And I think there's also, opportunities for collaborating with public health department to develop registries to link LTBI and chronic Hep B patients to care and improve the cascade of care infections. And as we saw earlier from the example in Orange County of, conducting community-based screening for LTBI and Hep B to increase education and testing. So next. So I think, the other areas I think that we would say that I'll highlight here in terms of public health and policymakers is, we did feel that there is a way that public health can engage with healthcare systems and healthcare providers to improve the cascade of care. I think, enhancing surveillance systems so we're able to really quantify the burden of TB and chronic Hep B co-infection seems to be a relatively important next step that I think can be done with some of the surveillance systems that exist. And I think for policymakers, really what we did feel is that, trying to reduce the cost barriers to LTBI and chronic Hep B screening and treatment, monitoring vaccination, and really I think if there were to some extent some CMS type quality measures regarding LTBI and chronic Hep B, we do think that cascade of care, those percentages would be improved. So next slide. So I think, what we did acknowledge as well is that, oftentimes, LTBI tends to be within the realm of a TB clinic or maybe primary care providers, but now more than not, a lot of our cases are very complex. They involve patients who are being managed by specialists, and Robert and I and Devin, Jagannath, and Robert Gish, really felt the need to write a review paper on, summarizing the diagnosis and treatment of LTBI for gastroenterologists. And so, we reviewed the LTBI diagnosis and treatment guidelines and summarized them in the table in the bottom right. And then I think we also provide and discuss common clinical scenarios of how we approach LTBI treatment. Some common scenarios like how do you encounter someone who's got co-infected with Hep B? How do you approach someone who's about to start on a TNF alpha blocker? And, we hope that would also be helpful because sometimes gastroenterologists are involved in the care of LTBI. And next slide. And I'll turn it over to Robert to discuss some of the other work that we've done.
Great. Thanks so much, Amit. And thanks everyone for having us today. Again, it's an absolute pleasure and honor to be presenting this breakout session. And really, as Amit was saying, the work that we're presenting here is such a nice example of starting with really a clinical case, something we worked on together. We shared some patients and started asking a clinical question. And as Amit and I were talking when I was at Highland about some of these questions, we realized that there were not a lot of data to help address some of the questions we had about these patients. And so, as we teach our house staff, when you don't find the answers to the questions, you do the investigation yourself. And that has really set off really multiple projects that we've worked on together and builds on some of these collaborations we've developed. And in the next, 15 minutes or so, I want to highlight some of the work that we've done together to try and better understand TB, Hep B epidemiology, and relevant to today's session, how we can potentially use this data that we've generated to leverage it to improve the care we provide for Hep B and TB patients. So this is one of the very first studies we started, really first trying to understand what is the prevalence actually of Hep B TB co-infection. Really the importance, I think, Amit sort of emphasized in some of his earlier slides about similar demographics, risk factors for these populations. Many of them have very similar underserved ethnic minority populations. And it's important for clinical care. And that's something I'll get to a little bit later. But just as a little bit of a teaser, understanding who has hepatitis B before you treat them with certain TB medications is important because some of these therapies do have risk of hepatotoxicity. And we're not really clear who will or will not develop, adverse events. But the only way to really understand that is to understand who actually has underlying chronic hepatitis B. So that's what really set us off. Next slide, please. So this first study, sorry, I'm working with dual screens here. I'm not going to go through this flow chart, but just to show you the rigor and detail that we did, doing a very thorough systematic review of the literature. As you can see on the very top, we initially started with over 1,200 articles. But as we went through and narrowed down based on our inclusion, exclusion criteria, and focused on studies that really address the question we were asking about Hep B TB co-infection, you can see we ended up here with about 36 articles that we then did a very thorough and comprehensive data extraction from. Next, please. Perfect. So this table here, or figure here, shows the forest plot of our meta-analyses. And it's a little bit busy, but I wanted to walk you through it. When we were trying to understand what is the prevalence of Hep B in populations with latent TB, we understood that TB and Hep B prevalence varied by region. So it didn't really make sense to combine them all into one aggregate. So we stratified them by world regions. Next, I have a little animation here. So a little circle here. These figures here, you can do next. Perfect. So these little circles here show the prevalence of Hep B among patients with TB in these regions. So as you can see here, in African regions, it was about 11.4%. In the Americas, much lower, as expected, about 2.15%. Eastern Mediterranean regions, about 3.3%. Next, please. And then we can do next to highlight the 3 circles. Perfect. You can see here that when we looked at European regions, Southeast Asia, and Western Pacific regions, there was very different prevalence rates of Hep B among TB populations. And this makes sense, but I think more importantly, it's also one of the first that really investigates what the prevalence of Hep B TB co-infection is among these populations. And that has some really important implications, especially in safety net type of health systems where we care for a lot of immigrants from these world regions, to think about the importance of disease prevalence and also the importance of screening for these populations. So this study was looking at prevalence of Hep B in patients with TB. Next slide. So then we asked the question the other way, what about the prevalence of TB in Hep B populations? What the thought is, sure, we should screen for Hep B in TB patients, but what about screening for vice versa? If I see someone in liver clinic with chronic hepatitis B, should I also be cognizant of making sure that these patients are screened for latent TB as well? We did the same systematic review, and as you can see here, again, started with a very large cohort of studies. And as we whittled it down, we realized there are very few data, actually. You can see here in the second to last box in the bottom, only 6 articles we found really address that clinical question that we were asking. Next slide, please. And this is the summary plot. There's not a lot of data, only 6 articles. And then one more click to highlight the circle of the prevalence. And you can see here, when we combine all of these studies together in the meta-analysis, what this tells us is, among patients with hepatitis B, the prevalence of latent TB was 34%. So very high. But this has to be taken with a grain of salt, because if you look at the figure above, you can see the vast majority of these studies were pretty old, 1986, 87, 91. In fact, there was only one relatively recent study that was done in 2019. So not only does it emphasize few data, it emphasizes the lack of high quality recent data to really help improve our understanding of Hep B and TB co-infection. So these 2 studies were our attempt at reviewing the literature. So both were systematic reviews and meta-analyses. We identified a gap in the literature. So when we identify a gap, our next step is, well, let's look at the original data ourselves and see if we can design some studies to really add to this literature. Next slide, please. So Amin and I worked together with a couple colleagues, Rezin, I think she's chief resident now, and then our research coordinator at the time. And first, we started with NHANES data, which has been used and validated in a lot of different studies. It's cross-sectional, as many of you know. And when we tried to look at both Hep B and TB laboratory markers, we realized that not every year were these data collected. So we focused on 2 survey periods where both Hep B and TB data, laboratory data, were collected. As you can see here, we defined Hep B prevalence by surface antigen. We also looked at Hep B core antibody to look at exposure. And then we defined latent TB, as you can see here, using both tuberculin skin tests or positive quantiferon. Next slide, please. And then one more click. This first table on the left was really evaluating prevalence of hepatitis B surface antigen among latent TB patients. The first row is the overall prevalence of latent TB in our population. As you can see here, total is about 4.2%. And then the first line below it is what we'll just focus on for this talk, is the overall prevalence of hepatitis B surface antigen positive in patients with TB. In the earlier period from 1999 to 2000, very few, 0.4%. It sort of increased, although the confidence intervals were wide, but numerically increased to 1.4%. And then overall, about 0.9%. So the way to interpret this is about 0.9% of patients with latent TB had positive surface antigen. Got to be taken with a grain of salt, as you all know, due to the relatively small sample sizes and the wide confidence interval. This is positive surface antigen. So next, we really looked at core antibody. So next figure, please. This table here, very busy, but just want to focus on just the top of the line data. This is looking at anti-Hep B core. What does that mean? Well, this means anyone that has been exposed to hepatitis B. And that's important. Not going to go into a lot of detail here in this discussion. We can talk about it in the Q&A if people are interested. But exposure to hepatitis B can lead to chronic Hep B, as we looked at for surface antigen. But it can also lead to so-called this latent, although I don't like to use that term, but prior exposure of Hep B, you always have some risk of reactivation from immunosuppression. So it's important to understand who has or has not been exposed to hepatitis B. Again, the top of the line here is the same, total latent TB prevalence. And then just focusing on the total line here, the prevalence of Hep B core remained relatively stable during the 2 periods, and we look at the total about 12.9%. So what does that tell us? About 1 in 7 to 1 in 8, maybe 8 is better. 1 in 8 patients with latent TB have positive Hep B core, meaning they were previously exposed to hepatitis B virus. So then moving on, next slide, please. That was NHANES, and we realized that while it's amazing data, there are some limitations. So we worked with a large national laboratory data to look at patients from 2014 to 2020, again, to try to answer the same question, testing patterns and prevalence of Hep B and latent TB co-infection. You can see here we define Hep B as is typical with 2 positive Hep B Hep B defining tests, and then we used TB quantiferon to define latent TB. But to be sure to ensure we were tracking latent TB, we excluded patients with active TB infection. Next slide, please. These are the overall top of the line data. The top here shows in our database, in our data set, what was overall prevalence. Overall prevalence of latent TB was 7.6%, slightly higher in men, 8.2 versus 7.2. As you can see here, when stratified by age, higher in the older population, maybe as expected. And then when we stratified by race ethnicity, was lowest in non-Hispanic whites, and sort of as expected, highest in ethnic minority populations, particularly Asians and Hispanics, 9.7% for Asians, 9.1% for Hispanics. Separately, when we looked at chronic Hep B prevalence, overall prevalence 0.51%, higher in men versus women. When stratified by age, seemed to sort of largest population was around the middle age group. And then as expected, again, when we stratify by race ethnicity, highest was seen in the Asian groups. And as you can see here, very similar demographics, and that's sort of the driver of why we were trying to understand better Hep B TB co-infection and the importance of screening in these disease states. Next slide, please. Very busy data, but just focus your eyes on the two highlighted columns. This represents, in patients with chronic hepatitis B, what proportion in this national laboratory data set were even tested. What proportion even had a quantiferon result? As you can see here, in the total, only 10.7% of Hep B patients were tested for latent TB. Not much difference in men and women. When stratified by age, seems a little bit of a peak in the age 18 to 29. And then when stratified by race ethnicity, looks like Blacks, African Americans, and Hispanics had higher prevalence of late quantiferon testing. When we look at what the actual prevalence was in those that were tested, very interesting. Among those that were tested, the prevalence of Hep B TB co-infection was 19.6%. Definitely increased with age, with the highest age group, 70 or higher, having a 29.5% prevalence of Hep B TB co-infection. And then when stratified by race ethnicity, again, very interesting and expected given the similar overlap of demographics. Highest prevalence was seen in Asian American, Asian Pacific Islanders. Next slide, please. When we flipped it around and answered it the other way, in latent TB patients, how many were tested for Hep B and what the prevalence was? Again, bring your eyes to the highlighted columns. First column shows what proportion of patients were actually tested. So as you can see here, among all LTBI patients, 32.3% were tested for some Hep B test. Among those, the prevalence of Hep B TB co-infection was 1.5%. And similar to the previous table, as you go down to look at men, women, age groups, and race ethnicity, you see somewhat similar patterns in that the highest prevalence of Hep B TB co-infection was seen in Asians. And again, that sort of resonates with all the patterns that we've seen in our studies, that they have similar demographics, similar likely immigrant status, similar countries, and again, emphasizes the importance of thinking about shared risk factors, shared demographics, and the importance of screening for these two disease states. Next slide, please. And then the next study we looked at is we acknowledge that there's a gap in testing, and there needs to be better data in prevalence. And our previous two studies tried to add to that literature. Then we looked at it at a different angle. We know that latent TB patients with underlying Hep B infection likely potentially have higher risk of drug-induced hepatotoxicity. And then some of the investigative agents for hepatitis B, especially those that stimulate or modulate the immune system, might have a risk of causing latent TB reactivation. So working with Amit and two of his colleagues at Alameda County Public Health, we looked at the clinical trial database of all chronic Hep B studies that are being investigated and looked at their screening practices. So next slide. Really, this shows again the detail that we went through. We started with 651 studies, and then after exclusion, we looked at 452 trials that looked at chronic Hep B therapeutic studies that had data to review whether or not they tested for TB, and then we stratified them here by whether they were from countries of high, non-high, or sort of unknown TB burden countries, and then we also stratified by the potential risk of latent TB reactivation based on mechanism. Really, the take-home here is the last bullet point that of all these studies, only 3 of the trials actually screened for latent TB, and 2 of them, or 1 of them was in low, but the other one was in a moderate, and another one was in a high latent TB reactivation risk agent. Next slide. So the main sort of findings from this study are, even though nearly 75% of Hep B trials were conducted in high-burden countries and 25% evaluated with an unknown reactivation risk, it's concerning that less than 1% of trials actually had documented data to screen for latent TB. And really, the point we try to push is to be more cognizant of the risk and really screening as prevention to really identify patients that might be at risk so that timely preventive care can be initiated. And then next slide, our final study to highlight is really a systematic review and meta-analysis that's under review at the moment, where we worked with one of our colleagues at Highland to bring the clinical aspect back to it. Why is it important to think about Hep B TB co-infection? Well, there's a potential risk of higher drug-induced liver injury. If you have underlying liver disease, particularly Hep B, you might be at higher risk of having a TB therapy-related hepatotoxicity. Next slide, please. We then did a very thorough systematic review. We ended up with a final set of 9 studies. So not that many, 9 studies that tried to answer this question. Next slide. And these were the summary of the 9 studies. We can click one more to circle the final summary data. And what this tells us is, what is the risk of drug-induced liver injury in patients with Hep B TB co-infection versus patients with TB without Hep B? And as you can see here on the summary risk ratio, when we combine these data in a meta-analysis, we can say patients with Hep B TB co-infection have a 1.85 or approximately 2 times higher risk of drug-induced liver injury compared to patients without underlying Hep B co-infection. Next slide, please. We did some sub-analyses next, and we focused on only prospective studies next, and we can circle here. You see the data were very consistent. Next figure, and then next circle. And then we only focused on data that were more recent data after year 2000. Again, the signal remains showing consistency of our data that there is, in fact, higher risk of drug-induced liver injury in patients with underlying Hep B. Next slide, please. And this is really just to highlight, it's been such a wonderful collaboration, and every time we talk, we have more questions and build upon our research. These are just a selection of 3 other projects we're working on to build upon this collaboration with the VA where I'm at and the CHECS cohort, which is a multi-centered hepatitis B cohort that we're working with. Again, trying to gather more data to answer these questions. What is the testing patterns of TB and Hep B? What is the prevalence of Hep B TB co-infection? And try to add more data to understand if there is, in fact, a higher risk of drug-induced liver injury. Number 2, we have a wonderful collaboration with some friends and colleagues at Kaiser SoCal, looking at the chronic Hep B cascade of care and treatment patterns, and utilizing the opportunity to also look at something what we're interested in, Hep B TB co-infection patterns and prevalence. And then finally, working with Devan Jagannath, as Amit mentioned a little bit earlier, at UCSF, to kind of look at national healthcare claims data sets to gather more data to corroborate our findings, looking at TB co-infection, testing patterns, prevalence, and looking at drug-induced liver injury. And then next slide, maybe I'll turn to Amit. Do you want to do the summary?
Oh, sure. Yeah, no, thanks, Robert. So, in summary, I think, what we noted, TB and chronic Hep B disproportionately impact non-US born persons, especially Asians. The prevalence of, chronic Hep B TB and LTBI chronic Hep B is at least, twofold higher among co-infected patients. What we noted from our, national laboratory database is that nearly 33% of LTBI patients are tested for chronic Hep B, while only 11% of chronic Hep B patients are tested for LTBI. The risk of drug-induced liver injury is twofold higher among, TB chronic Hep B co-infected patients compared to patients with active TB disease only. And, I think as we noted in the review paper, I think, reductions in TB and chronic Hep B morbidity and mortality really are going to require, healthcare provider system and policy level interventions to improve the diagnostic and treatment cascade of care for LTBI and chronic Hep B. And that's it. I think that's the end of our presentation.
Wow. Thank you so much, Dr. Wang, Dr. Chitnis, for that amazing presentation. Systematic reviews are the top of the food chain. They are very important to guide practice. So we have one question that came in earlier, and the individual asked, what were the major inclusion-exclusion criteria from the meta-analysis? And they know that you showed some in the slides. Were there anything significant that you guys want to point out?
Yeah, the main ones were, good question. For both, actually, pretty much all of the analyses, we focused on adults, and we focused on studies that actually had the data. And so as we went through and looked at the literature, we realized from our 1,200 articles, as we looked more deeply into it, sometimes the studies, while important and capture important population, actually didn't look at the right question or didn't have the data to answer what we were looking for. So it's mainly limited to adults, English language literature, where we can pull the data from PubMed. And other than that, we try not to limit it too much and sort of really capture a very comprehensive cohort. I'm not sure if Amit wanted to add anything too.
Yeah, I mean, I think the only other thing I'd just add is that, we looked at the publications, and if there are duplicate publications, we only took that presented the same data. We took one, and then we reviewed the the references and tried to see if we should add other papers that might not have been found in our strategy. So we tried to take a thorough strategy, and our initial search terms were developed with our librarian at Highland. So we tried to look at previous meta-analyses, use those search terms, and then worked really with her to refine them.
Wonderful. Thank you for that. We have a comment from Lisa Chen. She says, impressive, expansive work for Dr. Amit and Richard. Lots to absorb, but recognize that two of you are amazing champions for this cause. Thank you so much for that. We do have another question from Peter Davidson. He states, really stimulating for both of you. Would you suggest testing in both directions for co-infection, such as testing for TB infection among CHB patients and testing for HPV among LTBI TB disease patients?
Yeah, I mean, maybe I'll start and then I'll turn over to Robert. I think Peter, that's a great question. I think that's one thing that we would recommend. I think it does warrant screening for both of them. And I think as the patients that we had early up front kind of made Robert and I realize, like, are we actually doing that? And I think there's good reason from the epidemiology to do that. So yeah, I think it would be warranted.
Yeah, I totally agree with Amit, and I think that's the exciting thing about this work that we've worked on together. I mean, it started with a patient, we gathered this data, and I think that, what we're trying to push is that these data potentially can have practice-changing implications, like really trying to change guidelines and improve testing. And I do agree with Amit that, the data we've shown so far suggests that we should be testing both ways. TB in Hep B patients, Hep B and TB patients. And, as a side plug, I know this is a discussion that's also been going on, but, universal Hep B testing is something, I also believe strongly about. And I know there are data and discussions going on that. So that, that's also something else I wanted to mention.
Thank you. And I just want to put a plug in. So are we expecting a clinical guideline from your team regarding the testing? Based on all the data you collected, I believe you're very close to creating one. So we'll be looking forward to that from both of you. We are about out of time for right now. I just want to thank both of you again for your time and your dedication to improving the lives of TB patients and Hep B patients.
Thank you so much.
Thank you.
Thank you, everyone, and have a great afternoon.